Hello, everyone. This is Dr. Taylor. I'm making your recording. I'm sorry it's so late, but it was a lot of material because we had to go over those total of 6 chapters. So, in the future, if ever we have an incident where I have to recap something and I want to put it on video, it won't be quite so intense. So sit back and maybe about for 90 minutes or so and listen to what I tell you, the points that I pulled out when I looked through the book and I looked through the objectives that I felt were important for you to know. Okay, so we're going to start with chapter one. And chapter one was nursing today. And as we know, nursing is both an art and a science. The science is based on a body of knowledge that is constantly changing and evolving. The art is based on the practice of compassion, respect, and dignity rendered to the patient and family members alike. Remember, the patient is the center of your practice. The patient includes both the individual, the family, and or community that surrounds the patient. Making a difference in your patient's lives is fulfilling. When rendering care, you will be guided by a code of ethics developed by the American Nurses Association. You will hear that ANA and practiced by nurses. As you begin your practice, you will incorporate ANA standards, evidence-based practice, and critical thinking skills. As the weeks unfold, you will further on these topics areas based on uh, evidence-based practice as well as critical thinking. The history of nursing. Nurses. Nursing responds to the healthcare needs of society, which are influenced by economic, social, and cultural variables of a specific area. Through nursing research and evidence based practice, nurses have been able to carry on the traditions that Florence Nightingale began in the Crimean War. Florence Nightingale studied and implemented methods to improve battlefield sanitation during the Crimean War in the 1850s, which ultimately reduced illness, infection, and mortality rates. She set the stage for using evidence to direct nursing practice. Today, nurses are active in determining the best practices for patient care related to problems such as skin care management, pain control, nutritional management, and care of older adults. Researchers are leaders in expanding knowledge in nursing and other healthcare disciplines. Nurses exert great influences in social policy as well as political arenas. We have a strong organization, which is the ANA, and strong lobbyists who propose legislation to care for our patients. Knowledge of the history of the nursing profession increases your ability to understand the social and intellectual origins of the discipline. Although it is not practical to describe all of the historical aspects of professional nursing, some of the more significant milestones are described in the following slides that I'm going to introduce. Okay, so Florence Nightingale. And I'm going to just mention some people because I don't know what she put in the test, like I was telling you guys, but I'm basically capping the people and the things that I think is important that you should have some knowledge base of. So you got Florence Nightingale. Florence Nightingale believed that the role of the nurses was to help the body recover and then remain free from disease. In 1860, Florence organized the first school of nursing, the Nightingale Training School for Nurses, at St. Thomas Hospital in London. Nightingale was the first practicing epidemiologist. She used her keen mind and statistical analysis to show the connection between poor sanitation and diseases like they had cholera and dysentery. She volunteered during the Crimean War in 1853 and traveled the battlefield hospitals at night carrying her lamp. And you'll see pictures of that, where she was known as the Lady with the Lamp. As a result of Nightingale's organization and improvement of the sanitation facilities at the battlefield hospitals, the mortality rate at the Barracks Hospital in Scutari, Turkey, was reduced from 42.7% to 2.2% in as little as 6%, 6 months. The practice she advocated remained a basis part of nursing care in the 21st century. First practicing epidemiologists organized first school of nursing, improved sanitation in battlefield hospitals, and her practices remain a basic part of nursing today. So those are the things that you should try to keep in mind about Florence Nightingale. Okay, the Civil War to the beginning of the 20th century. Okay, the Civil War, which was fought from 1861 to 65, made nursing a necessity. Clara Barton. Clara Barton, founder of the American Red Cross, tended to soldiers on the battlefield. The U.S. Congress ratified the American Red Cross in 1882 after 10 years of lobbying by Barton. Okay, then you have Dorothea Lynn Dix, who organized hospitals, oversaw and appointed female nurses, and organized and regulated supplies to the troops. You have Marianne Ball, who they call Mother Bickerdike, who organized ambulance services and searched for abandoned wounded soldiers on the battlefield at night. You also have Harriet Tubman, who was active in the Underground Railroad movement and assisted in leading more than 300 slaves to freedom. And she was also, believe it or not, a lot of people don't realize this, she was an army nurse. You got Mary Mahoney. Mary Mahoney was the first professionally educated African American nurse. She may be one of the first proponents of better relationships between cultures and races and respect for individuals regardless of background, race, color, or religion. You have Isabel Hampton Robb, who helped found the Nurses Association. Um, um, and she was alumni of the United States and Canada in 1896. This organization became the ANA in 1911, and she also authored many nursing textbooks, including Educational Standards for Nurses back in 1907, and was one of the original founders of the American Journal of Nursing, the AJN. Nursing in hospitals expanded into the late 19th century. However, nursing in the community did not increase significantly until 1893 when Lillian Wald and Mary Brewster um, opened the Henry Street Settlement, which focused on the health needs of poor people who lived in tenements in New York City. Nurses working here were some of the first to demonstrate autonomy in practice. They often encountered situations that required quick problem solving and critical thinking without the supervision of a healthcare provider. So these are some things that is important for you guys to probably imprint in your memory bank. In the 20th century, um, you have a number of events began to shape nursing education in the 20th century. So in 1901, um, you have The American Nurse Corps was established, followed by the Navy Nurse Corps in 1908. Under the influence of Mary Adelaide Nutting, nurse education moved into U.S. universities in the early 20th century in 1906. Nutting became the first professor of the nursing at Columbia University Teachers College. Another important development in nursing history occurred when the Rockefeller Foundation approached Nutting, along with Lillian Wald and Annie Goodrich, to study nursing education. Their study, conducted in 1920 and published in 1923, concluded that nursing education needed financial support and should be centered in university schools of nursing. Nursing specialties began to emerge by the 1920s. However, organizations supporting these areas would not develop until the 1940s and 1950s. These organizations include the Association of Operating Room Nurses, the American Association of Critical Care Nurses, and the Oncology, which is Cancer Nursing Society. In 1990, the ANA established the Center for Ethics and Human Rights as well. On the 21st century, curriculum changes and need for strong and current knowledge is present. The nursing curriculum has continued to change to meet basically the changing societal needs. So issues such as bioterrorism, emerging infections, disaster management, and technology advances are among the newer additions to nursing practice and education. The End of Life Nursing Education Consortium, which is ELNEC, offered collaboratively by the American Association of Colleges of Nurses, which is the AACN, and the City of Hope Medical Center, has brought end of life care and practices into nursing curricula and professional continuing education programs for practicing nurses. The aging population, the high acuity level of care of hospitalized patients, which means acuity level meaning that they're very sick, they're very ill, and the early discharge from healthcare institutions require nurses in all settings to have a strong and current knowledge base from which to practice. Okay, changes in influences on nursing. So changes in society lead to changes in nursing. So you got healthcare reform not only affects how um, healthcare is paid for, but how it is delivered. There will be great emphasis on health promotion, disease prevention, and illness management in the future because those services will be in community-based care settings. As a result, more nurses will be needed to practicing community care centers, schools, and senior citizens. And so what that means is basically people are trying to get in front of it. Instead of being reactive, you're trying to be proactive. To effectively meet all the healthcare needs of the expanding and aging population, changes need to occur as to how care is provided, especially in the area of public health, to address healthcare reform and meet the needs of the changing population. And then you would need to ask yourself and think about what types of demographic changes affect healthcare and you got people moving from rural to urban centers, increased lifespan. How is that affecting healthcare? Increasing patients living with chronic illnesses. We have better drugs and therapies available, increases in alcoholism and lung cancer, and as well as other cancers. How is that affecting it? Caring for the medically underserved population is a global issue, and that's something that I'm really passionate about. The social, political, and economic factors of a country affect both access to care and resources to provide and pay for these services. To prepare for the threat of terrorism, the nurse curriculum and healthcare agencies are training future and practicing nurses to respond effectively to nuclear, chemical, and biological events. Nurses have increased responsibility at the local, state, and federal level in providing emergency preparedness, education, and preparing for disasters as well. We just went through basically a pandemic, with COVID and that type of thing. So you can think about those type of issues and what was you weren't RNs at the time, but what type of things uh, were we doing as nurses to prepare and to get in the line and try to beat that thing. Nurses are faced with multiple issues and hazards in the workplace, such as back injuries, repetitive motion disorders, and workplace violence. When looking for a new position, evaluate the workforce protection and safety plan the hospital or healthcare organization has in place. The nursing shortage affects all aspects of nursing, such as patient care, administration, and nursing education, but it also presents challenges and opportunities for the profession. With fewer nurses in the workplace, it is important for you to learn to use your patient contact time really efficiently and be very professional. And so think in your mind what other factors have influenced nursing? Technology, consumerism, health promotion, and the effects of the women's and human rights movement as well on nursing. So that would be something for you to sit and think about. Professionalism. Nurse is a profession. So what I'm saying to you is don't let people second guess that you are a professional and you're working in a profession. No one factor absolutely differentiates the job from a profession, but the difference is important in terms of how you practice. To act professionally, you administer high quality patient centered care in a safe, conscientious, and knowledgeable manner. Nursing is a profession because we share the characteristics of a profession. Now, in other exams that I've given when I've taught fundamentals in the past, I thought that it was very important for you to know what type of characteristics describes a profession. So you need to know these characteristics. You're working in a profession, you need to know these characteristics. Um, you will be educated. So it requires an extended education and you'll be trained to care for others. You will be required to take college or university courses to complete general education requires. So it requires an extended education. You will use a theoretical body of knowledge that guides you to develop skills and define your abilities and practice according to a clear set of norms. Okay? You will provide a service a specific service to others. You will have autonomy in decision making and practice, which means that we're going to trust that you know how to decision make. And that's something that we're going to work with you on when we say critical thinking. You'll hear that over and over and over and over again. Um, and you will incorporate a code of ethics which will guide your practice. Your skills, your body of knowledge you have mastered, the norms you will adhere to, and the service you will provide will make you a member of what they consider a particular profession. So we got professional um, professionalism continued. Okay, so education, licensed practical nurses, licensed vocational nurses, registered nurses, advanced, and continue uh, and in service. I would expect that you would need to know the difference between those particular things. The licensed practical nurse, for instance, which is the LPN, in some places they call them LVN, which is licensed vocational nurses, is a nurse who completes a practical nursing program and passes a licensure examination, which is an NCLEX, similar to RNs take an NCLEX, but theirs is NCLEX PN, which is practical nurse. The LPN and LVN practices under the supervision of a registered nurse. And this is important for you to know so that you can know your role and their role when you're out there working. A registered nurse or RN or other, they'll practice under other licensed personnel as well. An LPN or LVN, or in Canada, a registered nurse assistant, which is a RNA, generally receives 1 year of education and clinical preparation in a community college or other agency. There are some RN programs that allow an LPN to enter the program at an advanced level. So basically, all they're saying is that if you're already a LPN, there are some RN programs that allow them to test or whatever and enter the program and not require as much, like they're still starting from ground. There are various educational roles for becoming a registered nurse. RN right now in the United States, an individual becomes an RN by completion of an associate's degree, diploma, or bachelor degree program in nursing. Um, I don't see as many diplomas. Usually people have some type of degree like associates or a bachelor's behind their name. But when I was coming up, there was plenty diploma nurses. All of them at the beginning start take that same NCLEX. So we want you to know a minimal amount of knowledge in order to pass. The Canadian Nurses Association has identified the baccalaureate degree as the entry to practice standards for RNs in all provinces except Quebec. So they require you to have a bachelor to be an entry level nurse. There are roles for registered nurses to require advanced graduate degrees. A master's degree in nursing is for RNs with a Bachelor of Science in Nursing seeking roles as a nurse educator, which I am, nurse administrator, or an advanced practice nursing role like an NP. There are also roles with nursing that require doctoral degrees. I have a PhD. There are two doctor degrees options for nurses: the Doctorate of Philosophy, which is a focus on research, and the Doctor of Nursing Practice, which is focused on advanced clinical practice. Nurses with doctorates advance um, the profession by promoting evidence-based practice, conducting and disseminating research, developing and testing theory, and influencing public policies and health planning. So if you want to get out there and you want to influence, just like we have our thumb on you, and I'm gonna help, I feel like I'm helping influence and making nurses, and that's my passion. You can, of course, get experience and increase your knowledge. You're going to always be going to school on some level or learning or increasing your knowledge base while you're in the field of nursing. Continual education programs are a way to maintain current knowledge and acquire new knowledge. Continual education involves formal, organized educational programs. They're offered by university, hospital, state nurses association, professional nurses organizations, and educational and healthcare institutions. These programs often provide some type of continual education credit. So, like CEUs, you'll be required to get CEUs in order to maintain your license, which you renew every 2 years. So, you'll have a certain amount of CEUs that you need because they want you to stay current. They want you to stay, knowledgeable about what you're doing. but you'll find in-service education programs are provided by a healthcare agency or institution and are designed to increase the knowledge, skills, and competencies of nurses and other healthcare professionals. So a lot of times you'll see that um, uh like in hospitals or somewhere you may work there and they may be like, oh, we having an in-service on this or that. Oh, we just had this new pump that we decided to use, IV pump. Let's have an in-service so everybody can be knowledgeable about that. So that's a way for you to keep knowledge and go and do the things you need to do. Uh, so professionalism, um, so theory, service, autonomy, as well as accountability and code of ethics. Professional nursing practice and knowledge have developed in part through nursing theories, global views that help to describe, predict, or prescribe activities for the practice of nursing. Theoretical models provide frameworks for how nursing practice. The ongoing development of nursing theory or nursing science involves generating knowledge, uh, to advance and support nursing practice in healthcare. Nursing is a service profession and a vital and indispensable part of the healthcare delivery system. Nurses in practice today maintain a consumer and service-based focus. As a nurse, you will work with the patient and family, individualizing care while incorporating their preferences and expectations. Autonomy is essential to professional nursing and involves the initiation of independent nursing interventions without medical orders. Autonomy means that a person is reasonably independent and self-governing in decision-making practice. You reach autonomy through experience, advanced education, and the support of an organization that values the independent role of the nurse, which is really, really important. Accountability means that you are professionally and legally responsible for the type of and quality of nursing care provided. To be autonomous and accountable carries the reasonable responsibility, to keep current and competent in nursing and scientific knowledge skills. Nursing has a code of ethics that defines the principles that nurses use to provide patient-centered care. In addition, nurses incorporate doctorate advances the profession by promoting evidence-based practice, conducting and disseminating research, and you know, using various ways to advance the nursing practice. Okay. So, and if I'm moving quickly, you guys, it's because I'm going through like 6 chapters. It going forward, like I'm saying, you got me now, and we're going to go forward, and everything will be fine. So I'm just kind of doing the best I can to try to briefly overview some things. So let's do a quick quiz. Nursing is defined as a profession because nurses do what? A, perform specific skills. B, practice autonomy. C, utilize knowledge from the medical discipline. D, charge uh, a fee for services rendered. What makes nursing a profession? Okay, the answer would be B, because they practice autonomy. Remember how I told you guys that you need to know all the little components on what makes a profession, what makes nursing a profession. Requires extended education, requires a body of knowledge, provides a specific service, requires autonomy, and incorporates a code of ethics. So if you look down that list, you'll see practices autonomy. Okay. Okay. So that's the quick quiz. Okay. Let's go on forward. Standards of nursing practice. Three essential components. And if I'm moving fast, like I said, just bear with me because we got about 2 hours at least um, of me taping this. And I had to go and make notes and everything before I could deliver it to you. So bear with me, guys. I'm just trying to help you the best that I can to my ability. Okay. Standards of nursing practice, essential components of standards. Three essential components of professional nursing care, cure, and coordination. So, care, cure, and coordination is uh, uh, essential components. Caring is relational and requires you as a nurse to understand a patient's needs so you can individualize any type of nursing therapies. To cure and individualizing therapies and tweaking it and stuff like that is like very, very important in nursing. To cure is to help patients under their health problems and to help them to cope. The cure aspect involves the administration of treatments and the use of clinical nursing judgment in determining on the basis of patient outcomes whether the plan of care is effective. And coordination is meaning you working with other people. So you're using timing and you're trying to meet the holistic needs of the patient. A professional nurse also supervises, teaches, and directs all of those involved in nursing care. In the practice setting, it's important to have objective guidelines for providing and evaluating nursing care. Standards of nursing care are developed and established on the basis of strong scientific research and the work of clinical nurse experts. The purpose of a standard of care is to describe the common level of professional nursing care in order to judge the quality of nursing practice. An organization sometimes adopts a general set of standards for nursing care, such as organizational protocols, policies, and or procedures, as said. Okay, so Nursing Practice Act. Each state has its own Nursing Practice Act. Most Nursing Practice Acts are similar, reflect the growing and autonomy and expanded roles and scopes of practice. And then you have what they call licensure and certification. You will have an opportunity to practice in a variety of settings and many roles and this type of thing. So Nursing Practice Acts basically they establish specific legal regulations for practice, and professional organizations establish standards of practice as criteria for nursing care. The ANA is concerned with legal aspects of nursing practice, public recognition, or the significance of nursing practice to healthcare, and implications for nursing practice regarding trends in healthcare. In the United States, each state board of nursing oversees its Nurse Practice Act, which is NPA, and it regulates the scope of nursing practice for the state and protects public health, safety, and welfare. So, nurse practice acts may be tweaked or a little bit different depending on what state a person is in. This protection includes shielding the public from unqualified and unsafe nurses, although each state has its own NPA that defines the scope of nursing practice. Most NPAs are similar. In the last decade or so, many states have revised the NPAs to reflect the growing autonomy of nursing and the expanded roles like for advanced practice registered nurses. Licensure in the U.S. RN candidates must pass the NCLEX RN, a standardized examination for all candidates. Uh, Beyond the NCLEX RN, some nurses choose to work towards various certifications. Okay. Uh, in a specific area of nursing practices. Minimum practice requirements are set based on the certification that that particular nurse decides that she wants to meet. Okay, so you have responsibilities and roles of the nurse: caregiver, advocate, educator, communicator, provider of care, and manager. Okay, I'm gonna briefly describe each one of these because I need to really move on because you guys will be listening forever. And I suggest that, if you can upload it to like your phone or listen to it and you're riding in the car, listen to it. A caregiver. Nurses help their patients regain health and find their maximal level of independent function through the healing process. Healing involves the body, mind, and spirit. You're the advocate. Nurses protect the human and legal rights of their patients and help patients assert those rights when needed. You're the educator. As an educator, you explain concepts and facts about health, describe the reasons for routine care activities. You demonstrate procedures such as self care activities, and you reinforce learning or patient behavior and evaluate the patient's progress in learning. And you're a communicator, which is very, very important. It allows you to know your patients and include their strengths and weaknesses, and you may need to communicate with patients, family, and healthcare professionals in the community. You're the provider of the care. You're the one that's giving them whatever care that they particularly need. It could be in any type of setting: med surg area, emergency care, home care setting, and you're the manager. Your nurse manages and establishes the environment so that you can collaborate with other people to have patients in their care. And a manager coordinates members of the nursing staff to deliver nursing care and has personnel policy and budgetary responsibility for a specific nursing unit or agency. So this is very, very important when you talk about career development. And I know you guys are probably saying, my God, it's just chapter one. And I'm telling you, this was like a lot of information. And that was the reason why I told you guys, make sure you read those 6 chapters. Make sure you read them. You don't have to read them to study them, just read them because you'll be surprised at the stuff that'll come back to you and the information that you will retain just reading it. Then you take the parts that I'm telling you to study and you try to do memorization. But a lot of stuff is you have to know it and then you have to be able to apply it because you're not going to have that many questions that are just knowledge based. They're going to be questions to make sure that you can apply the knowledge that you are learning. Excuse me, need some water. Okay, so let me turn on this. Hold up just a minute, you guys. Okay, let's talk about career development. I want you guys to make sure that you know and understand the differences between advanced practice registered nurses, clinical nurse specialist, nurse practitioner, certified nurse midwife, and certified registered nurse anesthetist, which is the one that administers anesthesia. Okay, all of these fall up under the advanced practice registered nurse. You see how I have them listed: clinical nurse specialist, nurse practitioner, certified nurse midwife, the baby deliverer, and certified registered nurse anesthetist. Okay. Then you have nurse educator, which is what I am, a nurse administrator, and a nurse researcher. So these are advanced as you develop within your career, these are things. And I had put some notes like the APRN, Advanced Practice Registered Nurse, uh, is an independently functioning nurse. And then I told you about the four roles. And then the clinical nurse specialist is an APRN in a specialized area, like they could be critical care, geriatrics, diabetes, pain. The nurse practitioner, which is an APRN who provides health care, and they have different categories. Like you could be an adult family adult advanced practice registered nurse. You could be a family, pediatric, women, psychiatric and mental health, and geriatric. um CNM is a certified nurse midwife, and they are the ones who do help through pregnancy. A CRNA, I told you they do anesthesia. A nurse educator primarily works in schools of nursing, and a nurse administrator that kind of speaks for themselves. And then, of course, you have the nurse researcher. So it's important for you to know those things there, and you got to make sure you know the different what those particular roles are. You have professional nursing organizations, like you got the National League of Nursing, you have the ANA, American Nurses Association, the ICN, the NSNA, Nurses Student Nurse Association. I hope that a lot of y'all get involved with those. Those are really, really um, a lot of fun, and you learn a lot. And other professional organizations focus on specific areas. I want you guys to make sure you know what the difference is between these and what type of services and different things that you can do, so that, because like the NLN advances excellent in nursing education to prepare nurses to meet the needs of diverse populations and changing healthcare environments. The purpose of the ANA is to improve standards of health and the availability of healthcare. Okay. Uh, the A in A is actually a part of the ICN, which is the International Council of Nurses. Um, Nursing students take part in organizations. I told you about that. Um, and some professional organizations focus on specific areas such as critical care, nursing administration, nursing research, nursing midwifery. These organizations seek to improve the standards of practice, expand nursing roles, and foster the welfare of nurses within specialty areas. So, professional organizations present educational programs, as well as publishing various journals and stuff like that. So, you got a quick quiz. The NLN and the ANA are professional organizations that deal with what? You have four answers. A, nursing issues of concern. B, political and professional issues affecting healthcare. C, financial issues affecting healthcare. And D, all of the above. Take a minute. And the answer is all of the above. If you want to study and stuff, you can pause the video. And if you want to, go back and think about some things, you can do the book. So we got trends in nursing, quality and safety education for nursing, and you'll hear them talking about QSIN. Okay, one trend in nursing, QSIN addresses the challenge to prepare nurses with the competencies needed to continuously improve the quality of care in their work environments. You have patient-centered care and teamwork and collaboration, evidence-based practice, which basically integrates best current evidence while clinical expertise and patient family preferences and values for delivery of optimal health care, quality improvement, and safety and informatics. So those are basically, that's kind of self-explanatory, but I wanted you to know about the different trends in nurses and the different things that you need to uh, look at as far as nursing careers. And then also another trend, uh, the, knowing that like the nursing profession will continue to grow. You have genomics, is the study of inheritance, and it can influence treatment decisions because people can learn about genomics. And for example, if you got like the media frequently highlights incidents of preventable medical errors, such as medication and surgical errors. So, when you think about managing um, publications such as To Err is Human describe strategies for government, healthcare providers, industries, and consumers to reduce preventable medical areas. And genomics, when you talk about that, you can think about little incidences and little different things, as far as like, oh, I have this gene that says that I may get breast cancer, or my all my sisters had breast cancer. So I'm gonna jump on this right away. Nurses as a group are increasingly politically active. Professional nursing organizations at both the national and state level employ lobbyists to urge state legislators and the U.S. Congress to improve the quality of health care. You can influence policy decisions at a governmental levels. One way to get involved is by participating in local and national uh, areas. Okay? Now, we have finished and we are moving on to chapter 6. I told you guys it's a lot. It's a lot. It's a lot. It's a lot. But I'm going to try my best and my quickest to get you through it. And you can take a break. So it's not like, you can take a break. I took a lot of notes, and that's the reason why I'm telling you guys it took me so long to come up with this review. So let's continue on. Chapter 6, Health and Wellness. Okay, in the past, most individuals and societies, and I'm going to speed it up, viewed good health or wellness as the opposite or absence of disease. We now understand that some conditions of health lie between disease and good health. We view health from a broader perspective. So, good health or wellness is not necessarily the absence of disease. That may be something important to know. As a nurse, you will use concepts of health promotion, wellness, and illness to help your patients achieve and maintain an optimal level of health for that individual. You will use models of health and illness to understand and explain these concepts. And in addition, you will help patients make changes to their current health state to bring about improved health and wellness. Okay, so definition of uh, health is more than the absence of disease. Defining health is difficult because each person has his or her own personal concept of health. The World Health Organization defines health as a state of complete physical, mental, and social well being, not merely the absence of disease or infirmity. And that was from WHO, 1947. Individual views of health vary among age groups, genders, races, and cultures. So people view health in different ways. Health is a state of being that people define in relation to their own values, personality, and lifestyle. Nurses consider the total person as well as the person's environment to individualize nursing care and help patients identify and reach their health care goals. I would know the definition of health. Okay, you guys. I was also know the difference between the health belief model and the health promotion model. A model is basically just a theoretical way of understanding like a concept or an idea. Health beliefs influence health practice. Okay. Health beliefs has like three components: what the person perceives, uh how serious that person thinks that illness is, and the likeliness that the person will even take any type of preventive action. So the health belief model helps you understand factors that influence a patient's perceptions, beliefs, and behavior, and to plan care that will most effectively help patients maintain or restore health and prevent illness. So that's important to know. The health promotion model is basically a framework for integrating the perspectives of the nursing and behavioral science and the factors that influence health. This model focuses on three areas: the individual characteristics and experiences, behavior specific cognitions and effect, and behavioral outcomes. So it's directed at increasing the patient's level of well being. There's another model, basic human needs model, attempts to meet the patient's basic needs. You know, I don't remember if y'all remember Maslow's. Sometimes there are things with Maslow's about meeting a patient's needs and you knowing your levels of Maslow's as far as uh the hierarchy of needs and where to place this person. Then you have the holistic health model, attempts to create conditions that promote optimal health. Okay? So the holistic model is proposed by Mandel, is also known as a complementary or alternative medicine holistic model, complementary, people doing uh, different things like knowing about their spiritual well being, people doing acupuncture on top of, So think of holistic health model as people using other things, prayer or on top of. That doesn't mean that they're not going to do the basic things, but it just means that that's on top of the things that they would do for the health. Okay, I want you guys to know Maslow's uh, hierarchy of needs. Please, please, please. Some of you guys have probably learned Maslow's in psychology class or something like that. But if you've never been exposed to uh, Maslow's, I want you guys to know it. I want y'all to know. Listen, it has 5 levels. They're going to say what the lowest level is. The lowest level is physiological. The highest level is self actualization. That's when you got your stuff together. Okay. So you got to think of it like that. Okay. The lowest level is when a person is just meeting basic physiological needs such as oxygen, water, food, sleeping, and they even put sex in there. When these needs are not met, the affected person feels sick or irritated or complains of pain or discomfort. The second level, safety. First, physiological, then safety and security. The third level, love and belongingness. That's when you desire to belong in a group. The fourth level, self-esteem. That's when uh you wanna, that recognition from others. And then the highest level is self-actualization. Now people can bounce back and forth among the levels, okay? Um, and that's the desire of becoming everything that that person should be. people at that level are concerned with maximizing their potential. So you need to know that. Now they may explain, I don't know if she put this on the test, but I want you to know it because I guarantee you will see it if they give you an example. Everything is not going to be like name the 5 levels. It's going to be like, well, okay, we're giving you an example and we're going to give you this example and excuse me, and we want you to meet this example or we want you to know what this example means. Okay, what level is this person in? Can the person bounce back and forth between levels? Yes, they can. That type of thing. Okay? Quick quiz. According to Maslow's hierarchy of needs, which of these needs would the patient seek to meet first? Which one of the needs? Self-actualization, psychological security, shelter, love, and belonging. Remember, I told you the lowest rung, the first rung, is physiological. Tell me which one is physiological. That would be C, shelter. Remember, we talked about food and shelter and clothes and, just the basic what it needs to meet somebody. So that's the kind of thing that or how that would be. Okay. We're going to talk about 1970. There has been a national focus initiative toward better health for the American people. They have healthy people documents. Healthy people. The Surgeon General's report on healthy promotion and disease prevention, Healthy People 2000. You'll see us recommend now we're talking about healthy because it comes out every like it's uh two like every third decade or so. I'm sorry. And so here, like you got Healthy People 2030 goals. So let's talk about that, and I would just be familiar with it. Healthy People 2030 goals: attain high quality, longer lives, achieve health equality, create social and physical environments that promote good health, and promote quality of life across all stages. The most recent of these documents includes 600 objectives covering 42 topics. Okay, new topic areas include adolescent health, healthy care, associated infection, and social determinants of health. So the document comprises 4 areas, and those are the 4 areas I just mentioned: to attain higher quality, longer lives, achieve health equality, create social and physical environments. So just kind of know and promote quality of life. Just and some of the stuff you're not going to be able to just really, really remember it, but if you're just familiar with it, it's really good. Variables influencing health and health beliefs practices. Variable means something out of the ordinary or something that is not really directly related per se to whatever this disease process is. So variables influence how a person thinks and acts. So people's beliefs about their own health as well as their health practices and the manner in which they care for themselves will ultimately influence their health status. Health beliefs are a person's ideas and attitudes about health. These beliefs often directly influence health practices, whether there's evidence to support them or not. Health practices are those activities that individuals perform to care for themselves, and many of the variables influence patients' health beliefs, health practices, and self care. So, that is what you have to know, and you need to know the difference between internal variables that affect the care, and then we're going to go into external. Let developmental stage, intellectual background, emotional factors, and spiritual factors. Those are internal variables. That is something for you to know. I'm going to read them. A person's concept of illness depends on the person's developmental stage. They could be a young person. They could not know or understand quite, their age. A person's beliefs about health are partially shaped by knowledge, education, and past experience. A person's degree of anxiety or stress influences health beliefs and practices, and spirituality is reflected in how a person lives his or her life, okay, and what they feel the meaning of it is. So you need to be able to identify that those are internal. If you think about what I'm telling you, those are internal variables, okay. External and they may ask you the difference between which one of these four things is a external variable, and you maybe have to like pick it out. Okay, family practices can be passed down in both positive and negative forms. If, as a child, you have immunizations, child checkups, and regular dental and eye examination, chances are you will continue to do so in your adult. Those are external variables. Social economic factors can greatly influence a person's ability to make hard decisions. If I am healthy, I need to buy food, pay bills, or buy clothes for the children, then that may affect how I take care of myself. I may let my medicine go because I may need to feed my kids. We know from experience that culture influence belief, values, and customs. A healthcare provider will need to be aware of diversity in cultures and to plan care accordingly if we expect patients to be compliant. We will see more of this in cultural diversity. So, if you know what that means. There are ways that you can make a person feel comfortable culturally and deal with all the things that they need to deal with without um, totally without you know them hurting their self or hurting their health. You may want to try to understand what their diet is and see how you can get a dietitian and see how you can fit that into it if that's a concern with their health. You may, you know what I'm saying, their practices and different things. And then we'll explore it back more. Let's talk about this quiz. After evaluating a patient's external variables, the nurse concludes that health beliefs and practices can be influenced by which one of these? Remember, external. It'll be D, socioeconomic factors. The answers were A, emotional factors, B, intellectual background, C, developmental stage, D, socioeconomic. Socioeconomic factors is external. All the other three that I named prior to socioeconomic were internal variables. Health promotion, wellness, and illness prevention. Health promotion, you need to emphasize health promotion, wellness strategies, and illness prevention activities. Uh, Health promotion activities, a good, how can I say, a good way is to maybe things like exercise, good nutrition, um, and you got to make sure that you help a patient like embrace what's going on with their disease process, certain diseases. Wellness education teaches people how, to care for themselves in a healthy way and includes topics such as physical awareness, stress management, and self responsibility. And that's very important. You want people to be able to take a role in their health care. Illness prevention activities such as immunization, protects patients from actual potential life threats to health. So illness prevention is when you do things like you're giving them uh, 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 um, the immunization. So, oh, we get a flu shot because of this. Okay. So Um, you need to know the difference between what they consider active and passive. Active and passive health care strategies. Um, like for instance, you got an example of they automatically have fluoride in drinking water. That's passive. You getting your fluoride because you just drinking water. You know what I'm saying? A person gets their vitamin D because they're drinking milk. That's passive because they like milk, let's say, and the vitamin D is just happens to be in the milk. But active things that you're actively taking part in is things like, oh, I'm actively doing weight loss, exercise. I'm actively stopping smoking or something like that. Those are active. I want you guys to know the difference between the three levels of prevention. You have primary, secondary, and tertiary. I will explain them briefly. You can study them more. If you have any questions, just let me know. Nursing care directed at health promotion. Got those three levels. So primary prevention. Listen to what it primary consists of. Includes health promotion, wellness education programs, immunizations, hearing protection in occupational settings, training to develop good body mechanics, health screening that you do like mammograms and the colonoscopies and prostate exam. All of those stuff is primary. That's prior to. Those are the things that you do to prevent the disease from developing more or less. Secondary prevention is provided in the home, healthcare facility, or skilled nursing facility. It includes screening techniques and treating early stages of the disease. You are trying to limit them. They got the disease, but you're trying to do things to limit that person um, getting advanced disease. And then tertiary is when they got the disease and you just trying to make them basically achieve a high level of functioning as possible, and that's called preventive care because it involves preventing further disability or reduced functioning. Maybe they had a stroke and you like, okay, we're gonna do this, we're gonna do that to make sure we're going to give them this so that they won't trip when they're walking. They already got the disability. You don't want them to fall and break their neck because maybe their left side is weak. So you're going to supply them with tools and different things so that they can ambulate. That's what that is. So know the difference. Quick quiz. You will use the concept of primary prevention when instructing a patient to primary. A, get a flu shot every year. B, take a blood pressure reading every day. C, explore hiring a patient with a known disability. D, undergo physical therapy following a cerebral vascular accident, which is a CVA or stroke. The answer is A, we're doing primary care. That's the type of questions you guys will get. Okay. Variables that increase the vulnerability of an individual. Okay. Variables. Genetic and psychological factors. Okay. Um, age, physical environment, and lifestyle. Those are the type of things that are variable that increases a person to be more vulnerable to um, area. So, for instance, Risk factor could be maybe a habit somebody got, a situation, or environmental condition. Genetic or physiological factors such as being overweight affect physical functioning of the body. Age, even though that's something the person can control because you're going to get older, that still increases the susceptibility to certain diseases because the longer that you live, the longer that you will be more susceptible to getting a disease. Lifestyle, smoking, drinking, using drugs, all those have negative effect. Environment, cleanliness, heat, cold, overcrowding, crowding, air quality. So all those type of things are potential risk factors, people. As far as risk factors, you need to help them identify and understand areas that must be changed to promote wellness and prevent illness. um you will do what they call a health risk appraisal of the person, and a lot of those health risk appraisals are basically like they have like numbers, and if you are between this and this number, you're low risk or you're high risk, so you can do that depending on what environment you are in, but I just want you to know about it. Modification and change in health behaviors, implement health education programs to help patients change risky health behaviors. So that's what you do. Stages. Oh my gosh, this is very, very important. The stages of behavior change: pre contemplation, contemplation, preparation, action, and maintenance. I want you guys to know the difference between these different stages of, like pre-contemplation. They a lot of times what they'll do, they have a table in your book, and what they'll do is they'll show you or they'll tell you, um, now, pre-contemplation is a person ain't even tripping off of basically their disease process. I'm explaining it to you. They're not even thinking about it or any, they're just going about their uh life. Contemplation is when a person may say, I know I need to, you know, stop smoking. They acknowledging that it's there, for instance. Okay. Preparation is a person saying, okay, when I finish this last pack, I'm not smoking no more. They may say something like, oh, I bought me some nicotine patches to get ready. And then action is when they actually go through it. Then maintenance is when a person has kicked whatever habit or have maintained or mastered whatever it is they need to do for their health, and they're just going about it. I have seen questions before where people ask in what stage. They'll describe, um, they'll describe this person is doing X, Y, and Z, what stage are they in? Okay, illness. A state in which a person physically, emotionally, intellectually, socially, developmental, or spiritually function is diminished. At times, an experience with an illness will motivate a person to adapt and do positive behaviors. It is good to remember that an illness does not always indicate that a disease is present. Acute and chronic illnesses are two general classifications of illnesses. Okay. An acute illness is usually short term and severe. The symptoms appear abruptly or intense and often subside after a relatively short period of time. A chronic illness usually lasts longer than 6 months. Potentiate patients potentially it'll fluctuate. Patients fluctuate between maximum functioning and serious health relapses that are sometimes life threatening. Know the difference between acute and chronic illnesses. I just told you what it was. A quick quiz. Ah, see this? Sally has decided to set aside 30 minutes a day to walk after work next week. Sally is in what stage of risk factor modification? She has decided this is what she's getting ready to do. So, but it ain't said that's it. Is and then the key is with her saying she's decided to do this and that she's gonna start it next week. That's preparation, which will be C between the A, B, C, D, and E. Pre-contemplation, contemplation, preparation, action, and maintenance. Illness behavior. I'm telling you guys, this is a long chapter. We're almost finished with it. I'm trying my biggest. We just got to discuss about the family, and then we'll go on to exercise and activity. Um, Illness behavior involves how people monitor their bodies and define and interpret their symptoms. People who are ill generally adopt illness behavior. These behaviors depict how people monitor their bodies, define and interpret their symptoms, take remedial actions, and use the healthcare system. Personal history, social situations, social norms, and the opportunities and limits of community institutions all affect illness behaviors. If a person think of themselves as ill, illness behaviors act as coping. Illness behaviors can often result in patients being released from roles, social expectations, or responsibilities. Just as internal and external variables affect health behavior, they affect illness behavior as well. So you need to individualize care to assist patients in coping with their illness at various stages. So you got internal variables, remember, and then you have the external variables. And we pretty much went over what those are as well. Um, so you got the how the behavior, the emotional, impact of illness on the patient and the family. Um, Illness is never an isolated life event. The patient and the family must deal with changes resulting from the illness. Listen to that. You got individual behavioral and emotional reactions. Um, Short-term, non-life-threatening illnesses evoke few behavioral changes in the functioning of the patient or family. But if it's a long-term, of course, because they're dealing with that stuff every day. Self-concept or whatever is your mental self-image, and a patient whose self-concept changes because of illness is sometimes no longer able to meet family expectations. Um, you got to think about the effect of illness on the body image as well. Um, I even went through that stuff when my parents were living, and that was just 2 weeks ago, early this September. I mean, 2 months ago, and I mean 2 years ago. I'm sorry, and it was a mess, and I'll have to tell y'all the story sometime when I get a chance. But right now, I'm just trying to get through this material and give you ideas of things to look for. Okay. So, the next chapter, you guys, is I do want y'all to just remember as far as the last chapter that this is very important and that you guys give support to individual members of the family and make sure because of the effect of the illness, know that there may be family dynamics that may often change where other people may take on leadership roles and different things like this. And sometimes it can often create tension or anxiety, within the family. So I just want y'all to know that. Chapter 38, which is exercise and activity. Um, I'm trying to finish because I want to look at college football. So, um, chapter 38, exercise and activity. Exercise is a physical activity for the purpose of conditioning the body, right? And you improve your health, you maintain fitness, and it is also a therapeutic measure. A program of regular physical activity and exercise has the potential to enhance all aspects of a patient's health. The actions of walking, turning, lifting, and carrying are all common nursing activities that require the use of muscles. To reduce the risk of injury, nurses need to practice proper body mechanics. Y'all just went through this. Uh, and remain knowledgeable of current research standards and guidelines concerning safe transfer and positioning techniques. Um, I want you guys to know the difference between body alignment, body balance, coordinated body movement, and friction. Okay, so I want, because those affect your posture and that type of thing. Body alignment. I've seen times in the past where they've had questions on this. It's the relationship of one body part to another. Body balance, achieved by low center of gravity, enhanced by posture. Coordinated body movement, a result of weight, center of gravity, and balance. Okay? And stance. And a lot of people don't really like these parts, but they have very good pictures and stuff in the book. Okay. Regulation of movement. I want you to know, let me see. Well, coordinated body movement basically means um, integrating the functioning of the skeletal, muscular, and nervous systems. So, I want you guys to know the difference between you have bones perform five functions: support, protection, movement, mineral storage, hematopoiesis, which is blood cell formation. So one, two, three, four, five. Yeah, I told you. And articulation or joint is the connection between bones. So the joint is the connection between the bones. I'm trying to think. I want y'all to know that tendons are the white glistening fibrous bands of tissue and they connect muscle to bone. And cartilage is non-vascular, supporting connective tissue with the flexibility of firm plastic material. So you probably want to know that. You want to know that gravity pulls on parts of the body all at once. And this is pretty, um, like basic knowledge, and it's just something I would just be kind of pretty much doing out different things, and I just want y'all to know. Right here, I got the pathological influences on body alignment, like congenital effects, like a person having scoliosis or something like that. Um, you got disorders of the bones, joints, and muscles, like osteoporosis or something like that, central nervous system damage, like any type of nervous system damage could regulate voluntary movement, and it could result in impaired body alignment and mobility. Like, and then of course, like musculoskeletal actual trauma, like a person having a contusion, a bruise, or a fracture. So that is, and then we got growth and development. All of that is pretty self-explanatory. It's nothing big. It's nothing um that I think any person would know. The body undergoing changes throughout the life, right? Um, Knowing that a lot of things change, especially for once a person get to the elderly age, I would think it would be important for you to know that that kind of thing basically decreases. Uh, like their movement decreases, they have atrophy of the muscle. I want you to think in terms of when you think of older people as everything decreasing. Okay. Critical thinking. I kind of put a lot of this stuff based on the nursing process, um, and just basically saying that you will use a lot of critical thinking when you take care of a person, and you will implement and help them, um, uh, maybe caring for them, or transferring them, or positioning them, or uh, assessing whether or not they have uh, uh, activity tolerance and that type of thing. And so they do have based on the ANA and that type of thing. And, they have all of the different uh, things that you would use as far as standards. And remember, I told y'all about the body alignment, and I want y'all to I want y'all to look at here where it says center of gravity, line of gravity, because I've had a chance where on the past, standing, sitting, and recumbent, I've had incidences where they may have asked people about how that looks and what the center of gravity is and where that starts, and basically how that looks. So, and mobility, in order to improve, of course, you're going to do range of motion, and that's based on everybody. Uh, you do different things. You don't want a person to get overly stiff or that type of thing like that. Um, and you evaluate their tolerance as they go along. You could do passive, you could do active, where you have the patient. Active just means active range of motion means that the patient is fully um, participating. Passive range of motion means that you're doing it like, you're doing the exercises. You may be moving their leg around or their arm around to keep it going, you know. Um, Let's look at this. A patient with a long history of arthritis complains of sensitivity and warmth in the knees. To determine the degree of limitation, the nurses should assess what? To determine the degree of limitation, the nurse should assess what? A, posture. B, activity tolerance. C, body mechanics. D, range of joint motion. The answer is D. They got arthritis, and they complain of warmth in the knees and sensitivity. So you're going to try to do range of motion on them, of the joints, to make sure that you um, decide how much they can tolerate. Nursing process assessment, patient expectations, perception of what is normal. Okay, so a patient basically is going to have a perception along with, you can't force a patient to do what they're going to have certain expectations. Your job is to try to help them meet their expectations and try to help them see past it if there's any way that they can do more for their self. Older adults, you gotta know that there may be a decline in physical activity. There may be changes in their joints and their flexibility, um, and also chronic conditions and medications can affect activity and exercise intolerance. So you just got to know these things about these people. Right here, I have a nursing process diagnosis, activity intolerance, risk for activity intolerance, disturbed body image fatigue, risk for injury, impaired physical mobility, acute pain, chronic pain. You got to know the difference between that acute and that chronic, impaired skin integrity, risk for impaired skin integrity. I always like to try to, because if you have a person and it's about activity and you guys will see when you start going to clinical that you may have to work, write or work and do a care plan, and maybe one of their problems you may have to do three, um, and maybe one of their problems may be activity, intolerance. You know what I'm saying? So, what you want to do is you want to get why is they got activity intolerance because they're in pain. Is it impaired physical mobility related to their osteoporosis? You know what I'm saying? So that type of thing. So look over those and just kind of go with that and see how you can do. And so then you guys, y'all are going to be planning. And I'm trying to think. I want y'all to look of an example of a care plan or something like that for impaired physical mobility. And I want y'all to look at how that's put together. And you'll work on that, but you need to have goals and outcomes. So you're going to always work with the patient and make sure outcomes must be measurable. It must be something that you can measure because if you can't measure, it's not doing any good. And when I say measurable, I mean things like um, I want this person to be able to lift um let me see, lift their arm up over their head within a week or something like that, and make sure the goals are something they can accomplish. And it's sometimes better for a person to have little bitty goals, little short that they can accomplish because what that does is that increases their confidence level. Okay, so you set the priorities based on the person's mental and physical health. And teamwork and collaboration. You're going to work with physical therapy, occupational therapy. You're going to get their family members if they have family members involved. And that's what you're going to do. And when you implement something and you promote health things, you're going to do things like 15 to 30-minute exercise, weight levels, glycemic control, which means basically, them eating healthy and not just fatty sugar stuff. Exercise activity. Your goal is to improve that. So we talked about y'all basically you guys saw the exercise and lifting techniques and when you were in lab last week. So we are not going to continue to go over that. Positioning, protect areas of bony prominences like the elbows and the ankles and that type of part. We talked about repositioning. There's nothing that you don't really know. You got the positioning devices, the pillows, boots, trochanter rolls, all of those things. You got that stuff when you was had the in service. That was kind of like a lecture. Hand rolls, hand. You do when you do that, that's so that a person um won't get contraction. And all of these are just basic pictures of you know a person these are pictures of good positioning techniques. So I want you guys to know the difference between semi-Fowler's position, and that's when the head of the bed is up 30 degrees. If a person is supine, supine, S-U-P-I-N-E, that means that the person is resting on their back, okay? When they're prone, they're on, that's basically on their belly, they're face down. And then you got the lateral side. So a lot of people they'll confuse supine and prone. So know that and know semi-Fowlers. And then you got the lateral, and then there's certain um and they're showing basically the picture of the lateral position. Uh-huh. And then you have and I showed you the Sims position. A lot of times is a semi kind of prone. You're not totally flat. You either on your right or left side, and they specifically say how one arm is flexed and the other one is resting down. So that's just something to know about Sims. And then we talk about transfer technique when you was in your in service. So a lot of this stuff is repeat. Remember, I told y'all about active and passive range of motion. Active, um, being the patient is actively doing a lot on their own, and then passive is when you're doing it. Uh-huh. So I just want y'all to know. You see that control fall there on the screen? They always say it's always important to have a gait belt, but I've had incidences where a patient have gone down and you have to just try to go down with them and control it so they won't hurt themselves. The most important thing with walkers, you guys, is to make sure that the walker is fitted correctly. Like for instance, where um they have their arms or like okay, they need to be light, they need to be about waist high, and they have to and they say that you're supposed to the elbow should bend about 30 degrees while holding on to the grips. Okay, so that's like an important thing to know. And then you know the difference. That's a picture of an actual quad cane. Um, and then they have what they call single straight leg cane. And then there is like certain walking techniques. Um, then you have crutches, which they have the lost strand of forearm crutch, and then you have the axillary crutch. The axillary crutch is the one that goes right up under your arm, right up under your arm. Okay. hmm And you got to measure for crutches, And just like you got to measure for walkers, I don't know if she's going to mention that um, to you guys on the test. And it was kind of hard. It was difficult because I was trying my best to, figure out and know what type of questions that she would ask. I would tell you to know the difference between 4-point alternating or 4-point gait, 3-point alternating or 3-point gait, and 2-point gait. When you walking, cause like the crutch stance. And here it is right here. Here's the pictures. That's the 4-point, and this is 3-point alternating, and then the 2-point. I think y'all should know that. So, and then the proper way to go up the steps. When ascending the stairs on crutches, a patient usually uses a modified 3-point gait. The patient stands at the bottom of the stairs and transfers body weight to the crutches. The patient advances the unaffected leg between the crutches to the stairs and shifts weight from the crutches to the unaffected leg. Finally, the patient aligns both crutches on the stairs. And then they repeat that. Okay. And then it's showing descending, which always kind of scared me. I don't really think that she probably will answer that, but that's just something that you can kind of review and look at on your own because it's really not. And then for evaluation, patient care, reassess the patient for signs of improved activity, and exercise tolerance, revise the plan as needed, patient expectations, and that's that. Okay, chapter 39 is on immobility, you guys. Hold tight. Okay, we're going to continue on, you guys, with chapter 39, immobility. Bear with me. I'm going to start going fast because I know that you guys are probably tired of listening to me talk about this. But I'm trying to figure out the things that I'm kind of skipping over some things, and I'm just trying to point out some of the things that I think that may possibly be on the test as far as the review. Also, I wanted to mention to you guys, you know, when one of the things that she was talking about when on the blueprint, and pay attention to the blueprint and pay attention to how many questions and different things like that are on. And also pay attention to that little list where it says uh, analgesics. And then she talks about, she names specific analgesics. And naming those specific analgesics, what I would do is, analgesics are for pain. I would know how that analgesic, like the action, how that analgesic stops pain. I think it was only like about 3 or 4 of them. What does it does to stop pain? I know acetaminophen was one of them, which is Tylenol. And I would know, okay, what's the normal dose and that type of thing. And I would know, if anything, what type of instructions would you give your patient, like side effects, like, oh, when you take this, you shouldn't probably drive because it makes you drowsy. And an overdose of Tylenol can affect your liver, like that kind of stuff. That's the kind of stuff that I think that you should know about and stuff when you talk about in terms of, you know, in terms of, dealing with, yeah, the medication part, the pharmacology part, more or less. Okay, so immobility to me, it kind of goes right almost along with the exercise and activity. Remember, we talked about movement, body, alignment, that type of thing. We already know body alignment and posture and that type of thing. I want you to know the difference between joints, tendons, ligaments, and muscles. I want you to know what's the difference between a tendon, what's the difference between a ligament. Only reason I'm saying this, and I hope that you guys are taking note of this, is because just from my experience in the past, I have seen that. I have seen that. Of course, immobility, the same way, like we was talking about exercise, you got abnormalities that, of course, like scoliosis and different things like that can affect your mobility, amputation, a trauma, anything like that can affect it. Ergonomics assessment protocol. Ergonomics is basically, you guys, the study of proper like body alignment and that type of thing. You know how like when you go to a job and you work a regular job and they'll see if your chair or your computer and your whatever is ergonomically fit. Because like for instance, let's say you sitting at a computer all day. If it's not aligned and your body is not aligned real good, it can result in you having back in, injury and that type of thing. Um, so there's been chances, times when the reason why they have lift teams and that type of thing, is because they were seeing that there were a lot of people that was having uh, uh, back injuries and stuff. You wouldn't believe it, when people would try to be getting their work done and would just be doing it. So immobility can result in these type of changes. Respiratory changes. People can have problems breathing, and that type of thing. It decreases the lung expansion, uh, respiratory muscle weakness and uh like your secretions and stuff don't move like they should. That's why and ultimate it could cause atelectasis, which is basically collapse of the alveoli or the lungs, pneumonia. That's one of the main things. You have metabolic changes that take care, like you're not processing your carbohydrates, proteins, and fats. Blood volume occur in immobile patients, resulting in diuresis, loss of electrolytes, calcium reabsorption, and hypercalcemia. All those type of things. The noble patient is at risk for constipation because of lack of activity, uh, and it stops peristalsis or movement of the intestines, hypercalcemia, um, orthostatic hypotension, which is cardiovascular, and that's why they tell people to, like, when you sitting at the edge of the bed, to dangle first and let your, because that's why a lot of times older people fall over, because they be having orthostatic hypotension. Like when they raise up, their blood pressure drops. Um, the body loses muscle strength when you're inactive. Uh, contractor, remember contracture, or what they call disuse osteoporosis, which and abnormality of the bones and that type of thing. So a lot of there's a lot of effects from being urinary changes, um Oh my gosh, people can get stones, renal calculi, urinary tract infections, all of those things that you probably wouldn't even think about would occur as a result of a person being immobile. You know, all of those things can occur as a result of somebody being immobile. And so disuse atrophy, which is basically, this is what this is showing, shortening of the muscle fibers and surrounding joint tissue. And that causes you to have what they call contractures, which is when a person's, I don't know if anybody's have ever seen it before, where they can't move their hands, they're in just one space or something like that. Foot drop, this is what this is showing on the right side of the picture, just from no use. So you notice the respiratory change in your immobilized postoperative patient. The change you notice most consistent with respiratory change. Respiratory. See, that's the key word in this. The change you note is most consistent with A, atelectasis, B, hypertension, C, orthostatic hypotension, D, coagulation of blood. They're already talking about respiratory, so the answer is A, atelectasis, which is related to, remember I said that's collapse of the alveoli? Most of the times when you hear people say atelectasis, they're just talking about collapse of the lungs. Okay. Psychosocial effects, emotional and intellectual responses. A person can get depressed, um, have social isolation, sleep disturbances, and impaired coping. Because immobilization, basically what it does is it removes the patient from the daily routine. So he or she may have time to just like worry about, I'm disabled, I'm thinking about this, that's all that's like on my mind, and it disrupts normal sleeping patterns owing to nursing intervention, and causes further behavior changes and affects coping patterns. So people have and social cultural, I mean, responses. It just kind of depends on where they're coming. Some people are stoic and they won't even tell you, or you won't even notice. Some people pull in. Some people are more outgoing with it. So it just kind of depends. So developmental effects, I would say know the difference between these developmental effects of okay, they got the kids, the babies, the adolescents, the adults, and the older adults. So prolonged immobility can delay motor skills in kids. That intellectual development and musculoskeletal development. Delayed in gaining independence and accomplishing skills, social isolation can occur on adolescents. Physiological systems are at risk, and changes in family and social structures. What they mean by that is, like, let's say you have a man who was the caretaker of the house, he was the breadwinner, and he had some type of immobile, maybe he hurt his back and was out. Well, that would change the way he felt about himself, his ability to cha- to to care for his family or that type of thing. Older adults increase dependence, functional losses in physiological systems. Right. So when they say increased dependence, you guys, that mean they're depending on people to take care of them. Okay. Critical thinking. Remember, I told you you'll hear that a whole lot. You apply elements of critical thinking whenever you perform the nursing process. So, consider the scientific knowledge you have learned. Um, you got to know about pathophysiology and why things are happening the way that they are happening. and you take care of patients who have mobility restrictions in the past. That allows you to anticipate patients' needs to comfort, pain control, positioning, and support of ADLs. ADLs, activities of daily living. That means like washing, grooming, you know, that type of thing. Experiential learning also occurs during visits to a physical therapy unit in the hospital or in the community. And you just have to have standards and know that you are promoting the patient's independence and that you are coordinating patient care. So remember, all these things, all these systems I already discussed with you about how they affect the systems. I've discussed with you how it affects older people. Um, their functional status, their activity tolerance changes. Remember, I told you about the behavioral changes, depression, and everything. I kind of basically, you know, captured that in the previous slides that I did. Remember, I tell you, I'm always going to give you some nursing diagnoses. You got them nursing process diagnoses: ineffective airway clearance, that's the respiratory, risk for constipation. Hey, that's the so you're gonna do things to stop that. That and if you have a nursing diagnosis book, or you can even Google nursing NANDAs, NANDA, where you can get diagnoses. You can Google it. Risk for constipation, risk for disuse syndrome, musculoskeletal, risk for falls, impaired physical mobility, right? Risk for impaired skin. If they immobile, they can tend to skin can break down, right? Risk for deficient fluid volume, impaired urinary elimination. So there's things that can happen when you're immobile. It's like your body and different things tend to shut down a little bit, okay? So you can have a care plan for a person because there could be a lot of things. That's why it's really good for you to assess a patient and make sure that you are trying to tune in to all the different things that are of effect. And you don't have to get fancy with it and all of that. You just need to communicate what things you feel or could potentially be, because that would be a risk, or or seem to be a problem with that patient. And that's the reason why you assess the patient. That's the reason why you can know this has potential to affect this, and you just take it from there. Nursing process planning, you always going to do goals and outcomes, patient centered goals. Always, like sometimes a lot of places have care plans and different things like that. And they'll have those different things, um, as far as the care plans and everything like that. But you need to make it real for that patient that you are taking care of. So that's why they always say patient-centered goals. Uh, don't give a goal that's unrealistic for that patient, you know, that that patient can't accomplish that goal. The effect that problems have on patients' mental and physical health determines the urgency of any problem. So, and then the patient family specialists and community resources. All of that stuff is important. You may want to prevent disuse syndrome by making sure that you exercise a person every 2 hours in the 24 period, or or every 4 hours, or turning them, or all the little different things that you're doing. You need to do those things, okay? And then health promotion, preventing work related injuries. Remember I told y'all about ergonomics, using proper body mechanics, fall prevention measures, uncluttering the place, exercise, making the person's core stronger. These are all teaching moments, you guys. These are all things that I've already went through implementing, promoting the expansion of the chest and the lungs. They have things that you can use uh, uh, to cough deep breathing, incentive spirometers that they blow on when they have had surgery, for instance, or when to help expand their lungs. Uh, Adequate nutrition, that prevent thrombus. Y'all know thrombus is a blood clot. Musculoskeletal prevent disuse syndrome, 2 hours in a 24 hour period, preventing pressure ulcers, skin integrity. I mean, there's so many different things that you guys um, could work on when it consider you got somebody that's immobile, and then there's always things that you can do to help that person, you know, take it further. Respiratory, maintain a patent airway, exercise. I mean, it goes on and on. Anti-embolotic elastic stockings. Um, you can delegate that to nursing assistants to put those on for you. You know, they prevent venous stasis and stuff like that, and they improve venous return. So make sure you don't massage the legs. Make sure you don't have wrinkles in the stocking. So make sure the stockings are fitted really good. Make sure that the nursing assistant informs you, tell them if the patient complains of leg pain or leg swelling. So, um, that's the reason why you would do that. So, yeah, you would put them on applying. They showing the proper way to apply the stockings. And you have to be careful because I know some of those people have it's very difficult to put the stockings on, you know, and that's why fit you want some firmness on it, but you don't want it where it's so tight that it is bothering the patient. But I mean, I've worn anti-embolic stockings when I go to clinical, because I'm on my feet and I like them. They keep your feet or your ankles from swelling. As you get older, I don't care how much you exercise or whatever, you may tend to have, problems and stuff like that. Every now and then. Mine's is not severe. And then that's why it's very important to tell people to exercise. Okay, look at this right here, you guys. Look at where you see where that gentleman there has the foot propped up on the pillow that promotes venous return, elevating. And then it also what it does is it stops that the cush, like that constant pressure. You got to watch people. Okay, then you're applying sequential. You may hear people say SCD, and you may see that in the chart. And what it is that you see how they apply that, and you make sure that it's not aligned. When you apply it on the leg, that you could put a finger in there so it's not too tight, and then they'll put so many millimeters of mercury that'll be in the order, and you collect it. And what they do is once they apply that and everything like that, or once they apply, um it cycles. And so every so often, it may be every 5 minutes or every 15 minutes or whatever, it'll inflate and then it'll let off. You know what I'm saying? So it's almost like um a it's a mechanical unit that basically compresses and keeps the circulation going. So they're real neat. A lot of times they give it to people that are older or people that can't move. Maybe they've had hip surgery or maybe they've had, for whatever reason. So here is another, you guys, quiz. After completing preoperative teaching for a surgical patient, you can evaluate the patient's understanding of the use of elastic stockings when the patient states what? What they're saying, after completing preoperative teaching for a surgical patient, you can evaluate the patient's understanding of the use of elastic stockings when the patient states, I can remove them at night. I can roll them no lower than my calf muscle. I wear them no longer than 4 hours at a time. I can remove them for 30 minutes every 8 hours. So what this is basically saying that which one of these, because they say the answer, which one of these seem like this is the right one for a surgical patient. So they need their elastic stockings. They're gonna wear them, uh, and probably just take them off to just like groom and stuff like that. And stuff, wash and stuff, and they'll put them back on. This is I can remove them at night. Is that true? No. I can roll them no longer than my calf muscle. You're not supposed to have any rolls, any kinks, anything like that in the right? I wear them no longer than 4 hours at a time. That's not true. Okay, so I can remove them for 30 minutes every 8 hours. That seems more realistic. So the answer is D. Okay, musculoskeletal exercise range of blah, 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 blah. Okay, so basically all this is showing is somebody has had surgery or whatever on their leg and they have different units and things like this is what they call like a CPM. Let me go back so that you can see it. This is called continuous passive motion. A lot of times they use this when a person um has had like maybe they had a niche surgery or something like that. And what it does is it helps them exercise because what it'll do is it'll push back and then it'll extend and then it'll push back and then extend like that. And but the doctor is or the physical therapist or whoever is responsible for the setting or how far to go. But that's when they're not exercising and up around with physical therapy and they're laying in bed, they're constantly want them to be doing something to make that knee or whatever stronger. But that's what they use that CPM for. I want you guys to know you got although okay, every 1 to 2 hours is recommended for preventing ulcers, but sometimes you need devices and stuff to relieve pressure. Um, patients sitting uninterrupted in a chair is limited to only 1 hour. Okay, and patients to shift their weight every 15 minutes. So that is what the purpose of this is. Psychological problems, psychosocial problems. I'm sorry, y'all. Oh, I guess I'm getting tired. We've done a lot. Establish a balance among rest, and stuff like that. People need to make sure that you try to coordinate your visits and your the different things that you're doing to the patient between 10 p.m. and 7 a.m. Nurses provide stimuli to maintain the patient's orientation. Make sure that if they're in a private room, that you have newspaper, books, crafts, computers, television, and radio, and stuff to help them pass the time. You know, you don't want them in there feeling like they're, in a bad way. And older adults, they may be at risk for cognitive changes, especially if they've developed a urinary tract infection or something. They may get depression, or they may have problems related to taking certain medications. So you want to test them and question them based on that. Safe patient handling and movement. Explain the movement or transfer process. Use the patient's strength when lifting. Safety is the first priority. Remember, you guys kind of learned all this stuff when y'all was at having your thing on Wednesday. So a lot of this is repetitive. And I think that if you was really listening, and that's why I was telling you guys, get up, go look over there. You learning and nothing is changing, and there's no tricks, you know what I'm saying? It's all like the same, so if you was paying attention and you really know and stuff, you pretty much uh got it. I wanted to say something as far as it says here, restorative and continuing care. Instrumental activities of daily living, activity of daily living, and use of devices. Blah, 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 devices. I'm sorry. Okay. I just wanted to say to you guys that know the difference between IADL, which is instrumental activities of daily living, and ADL, which is activities of daily living. They even have advanced activities of daily living, but I guess people aren't talking about those right now. So I'm just going to say, um, IADL, which is instrumental activities of daily living, include things like such as shopping, preparing meals, banking, and taking medication, and being able to do your ADL. Okay? So they're doing things that they need to do in order to keep their lives going. So if you take it like that, I can take my own medicine, I can prepare my own meals, I can shop, and I can give myself a bath and stuff. I'm just down right now. That's the IADL. When you talk about people who have, there's the category AADL, like advanced, it may be AADL, but I think it's AADL. Advanced activity of daily living. Those are the people like, oh, I'm going to the soccer game and the hockey game, and they're going out and entertaining themselves and stuff like that. That's the difference. So if you know the difference between just ADL, being able to give yourself a bath and that kind of stuff, and IADL, if you know the difference, you're that may be possibly on there. I'm not sure, you guys, but I just wanted to mention that to you. Okay? Okay. Evaluation, patient care. If expected outcomes are not achieved, revise the plan of care. Okay? And then you keep moving. You always got to tweak stuff. That's how people live their life. They tweak stuff. You see if something is working, and if it's working, then you say, okay, good. But if it's not working, then you go and you tweak it. Okay. The next is chapter 43, sleep. We're almost there, you guys. Bear with me. Chapter 43, sleep. I think we have done, am I, and then we go to pain, and I think after we do pain, we will be done. So bear with me, cause I get it. You know what I mean? I get it, you guys. I really do. Okay, but we won't have to go through this ever again. So y'all got me now, okay? And I'll keep y'all abreast, and I will be the one making the test questions. So don't worry about it. Chapter 43. Sleep. Physical and emotional health depends on adequate sleep and rest. Without the proper amount of rest and sleep, the patient's ability to concentrate, make judgments, um, promote healing, and participate in daily activity decreases. And of course it does. This week I was really tired because I was running around and I was doing a lot. And I knew that I had to work on giving you guys some type of review because that's what I promised that I would do. And I was like, oh, how quickly. So I spent all Thursday, I had to go out to the hospital, Lakeland, because they had a orientation. I didn't have time to do it then. Then Friday came. And so Friday I went over to the office, but it took me half the day to just like try to find. I'm looking through the book and I'm um basically what I'm doing is I'm looking through the book and I'm looking at the I could say the objectives in the chapter, and I'm looking over everything, and I'm trying to go by what I know, and I'm taking notes, and I'm typing up notes. This is important. This is important. This is, oh, let me devise a PowerPoint and then put, notes down there to make sure I mention this and that, and then I'm not knowing exactly what is all going to be on there. So y'all are just going to have to be super smart. Okay. So it was tiresome. And so when it came up to the last night, I was like, whoa, I was knocked out last night. And what I did was I had all my notes, I had all of that done, and then I have things, like people have a life and they have things that they have to do. And so I got to taping, and I've been taping now for 2 hours, but I'm gonna get it to you, and I'm gonna get it to you early in the day, so at least you will have um this evening, Sunday, Monday, and Tuesday to listen through the tape. And I hope you took my advice when I did the post and you did things that I told you to do, because you should go in feeling pretty secure. It shouldn't be that bad. So speaking of sleep, that's like a must. And people get tired, so we sleep is a cyclical physiological process that alternates with longer periods of wakefulness. The sleep-wake cycle influences and regulates body function and behavior responses. Remember, people sometimes they get cranky when they don't get enough sleep. Okay, circadian rhythm is everyone's day-night 24-hour clock. This is why we need to pay attention to the patient's work, school, and life patterns and be aware of how they are affected when hospitalized. Every person has a biological clock, you guys, and that is normally synchronized by exposure to light and activity. Explains why some people fall asleep at 8 p.m., whereas others go to bed at midnight or early in the morning. Different people also function best at different times of the day. Factors such as social activities and work routines affect circadian rhythms and daily sleep wake cycles. Hospitals and extended care facilities do not usually adapt care to an individual's sleep wake cycle preferences. So, when the sleep wake cycle becomes disrupted, other physiological functions change as well. They have a decreased appetite, weight loss, you got anxiety, restlessness, irritability, and impaired judgment and common symptoms of sleep cycle disturbances. Okay, so let's discuss the regulation of sleep. Okay, and this is, I know you guys, this is boring, but I'm gonna just tell it to you, and I don't know how deep in she gets. The control and regulation of sleep depends on balance among regulators within the CNS, the central nervous system, the central nervous system being the brain and the spinal cord. Changes in peripheral nervous system, endocrine, cardiovascular, respiratory, and muscular systems will affect the patient's sleep pattern. The major sleep center is located in the hypothalamus. You may know that. I don't know. Instruments such as EEG measures electrical activity in the cerebral cortex. The EMG measures muscle tone, and the EOG measures eye movement, provides information about some structural physiological aspects of sleep. So no EEG, EMG, and EOG. I told y'all that. The hypothalamus secretes hypocreatinins, which are like a form of peptide that promote wakefulness and rapid eye movement. Rapid eye movement, you'll hear them call that REM. Okay. Researchers also believe that the RAS, which is the reticular activating system located in the upper brainstem, contains special cells that maintain alertness and wakefulness. The homeostatic process, which is process S, primarily regulates the length and depth of sleep, and the circadian process C, which is the biological time clocks, which influence the internal organization of sleep and timing of duration of sleep-wake cycles. I don't know if they're going to go this deep. I don't know. And so I'm just telling you so you'll know you heard it. Time of wake up is defined by the intersection of process S and process C. So know the difference between the C and the S. That's all I can tell you. Okay? No, yeah. I would say know the difference. And I would also say know the difference between the stages of sleep. Okay? Um, you have two phases. Normal sleep, which is normal sleep. You got the non-rapid eye movement, which is NREM sleep, and rapid eye movement, which is REM sleep or EM. During NREM sleep, an individual progresses through four stages during a typical 90-minute sleep cycle. The quality of sleep from stage one through stage four becomes deep. So you start at stage one, and that's lighter sleep. One and two, a person is more easily aroused. And then stages three and four involve a deeper sleep called slow wave sleep, from which a person is more difficult to arouse. So they have the NREM and which is a 90-minute cycle, you guys. As they progress, one and two is lighter, you can arouse a person. Three and four is heavier, they're harder to arouse. REM sleep is the phase at the end of each 90-minute cycle, and during REM sleep, that is increased in brain activity associated with rapid eye movements and muscle atonia, which means when you say muscle atonia, it's like, you know, they're stiff. Okay. Narim, you see the cycles, pre-sleep and sleepiness. And then you see it's just kind of showing you like the stages and stuff. Okay. So I don't know, but I'm just telling you that I'm touching on that light, and I'm hoping that that is how she's gonna touch on it about the purpose of sleep, the purpose of sleep, It's restoration and preparation. And then y'all know that sleep deprivation negatively alters body functions in different ways. Um, Let me see. Dreams occur in non-rapid eye movement and rapid eye movement sleep. Okay. Important for learning memory and adaptation to stress. So if you lose that REM sleep, that last little bit at each 90-minute cycle, they say that it leads to confusion and suspicion. So, and the dreams during when you having the rapid eye movement are more vivid and elaborate than those of NREM sleep. So, I guess. Okay, rest contributes to mental relaxation, freedom from anxiety. Sleep provides restoration of energy and repair and recovery of body functions. So that's an important thing to know. Woo, you guys. Neonates needs up to 16 hours a day. So they need 2/3 of the time they need to be sleep. Okay. And then you got infants needs 9 to 11 hours at night with naps during the day. Toddlers and preschoolers 12 hours total. School age 9 to 12. Adolescents 8.5 to 9.5. And they want you to at least get 7. And then young adults get 6 to 8.5 hours, probably because you're busy. Middle and older adults, total number of hours decline. And I've known that too, because I think it's because you're not as active when you get older. And so therefore you don't need as much sleep. You know what I'm saying? So you need to make sure that if you got adolescents in school or whatever, and if they got excessive daytime sleepiness, they gonna have reduced performance in school, vulnerability to accidents, behavior and mood problems, increased use of alcohol. People do that kind of stuff. Also, because you know alcohol is a depressant. In middle age, the amount of stage 4 sleep begins to fall, a decline that continues with advanced age. So that's the factors that's affecting sleep. Okay. Physical illness affects all these different things. I'm not going to read all of them. If y'all want to just look over physical illness, those are the types of things that contribute to a sleep disorder of any type. Okay, a 4-year-old pediatric patient resists going to sleep. To assist this patient, the best action to take would be adding a daytime nap, allowing the child to sleep longer in the morning, maintain the child's home sleep routine, offering the child a bedtime snack. What is it? Kids like routines, maintaining the child's home sleep routine. Okay, so then you guys, there are various types of sleep disorders, and I want you guys to know them. So I want you to know the difference between these sleep disorders and stuff, because I don't know, she may drop one on there. Insomnia. When a person has insomnia, that means that they have situational stress. Poor sleep hygiene, underlying physical or physiological disorders. Sleep apnea is caused by upper airway obstruction, you guys. Lack of airflow through the nose for periods of 10 seconds or longer. Three types of sleep apnea are what they call central obstructive and mixed. The most common form is obstructive, and that will cause excessive daytime sleepiness. They have structural abdominal obesity, all those different things cause sleep apnea. Narcolepsy, caused by a rare central nervous system dysfunction, maybe with or without cataplexy. What I need to tell y'all about cataplexy, that's like a muscle weakness, so that y'all will know what that is. And uh, there are two types of narcolepsy. Um, and they got the kind that don't have muscle weakness and the kind that do, which basically intense emotions such as anger, laughter, and that may occur all over anytime during the day. And so a person can fall asleep on you, and that's something they can't control. Sleep deprivation caused by illness, stress, medication, environmental disturbances, variations in the timing of sleep. So a lot of little different things could cause sleep deprivation. That means basically I'm not getting enough sleep. Insomnia, what's different is that I can't sleep, even though I have the time to sleep, I can't. So that's the distinguishing factors between both of those. Parasomnias are things like sleepwalking, night terrors, nightmares, teeth grinding, bedwetting. These are things that are most common in children, and these are things that happen. So I just would tell you guys to just know what the difference is, because maybe she might put a question where she may ask you what the difference is, or describe a situation. Johnny, is walking around, blah, 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 at night, and or this person is doing this, and you know, you know what I'm saying, and may ask you what it is. This best describes what, and they may have some things on there, and sometimes they'll put things on there that ain't even one of the five things that I even mentioned. So uh, during rounds, see on the night shift, you'll note that a patient stops breathing for 1 to 2 minutes several times during this shift. This condition, this condition is known as what? Okay, cataplexy. That's like weakness, you guys. Cataplexy. That's like weakness. Is that a thing? Cataplexy? Is it insomnia? Is it narcolepsy or is it sleep apnea? Well, the answer is D, which is sleep apnea. Remember, stops breathing for 1 to 2 minutes several times during the shift. Okay, that's sleep apnea. Okay. You're going to use critical thinking, and you're going to try to do the things that you need to do as a nurse, um, in order to get the person where they need to be. Um, it says experience, personal and clinical attitudes, perseverance and creativity, and standards, intellectual as well as professional. So you just need to work with them to promote whatever therapies you need to promote for them to better get sleep. Nursing process assessment, assess a patient's sleep pattern to gather information about factors that usually influence sleep. Is it sleep habits? Is it sleep problems? Patient, bed partners, parents, all of those type of things can assist you in getting your assessment. Here is once again, like you guys, I'm giving you some things deal that are assessments, sleep history, sleep pattern quality. You want to grab all those things when you're doing uh, your assessment. Emotional and mental status, bedtime routines, bedtime environment. Maybe it's not comfortable where they are. Maybe they on some medication. Maybe, it could be a lot of things. And you got to know specific behaviors. Okay. Um, Remember we talked about older considerations. They have a decline in REM. Circadian rhythms change as the body ages, but they require 7 to 8 hours of sleep per day. Sleep disturbances are often related to illnesses, medications, and losses. Assess needs and preferences. Okay, here is a list of nursing diagnoses related to sleep disturbances. They could have anxiety because that could be what's affecting their sleep disturbance. Ineffective breathing pattern, acute confusion, effective coping, fatigue, insomnia, disturbed sleep problem, sleep deprivation, ineffective health maintenance, readiness for enhanced sleep. So those are nursing diagnosis. I want y'all to get in y'all nursing diagnosis book and start looking at that. So you're gonna plan, and you're gonna plan outcomes established over a realistic time frame, right? Focus on the goal. Remember, always have a time frame, and always have measurable things, and always have things that you know that you can achieve. Focus on the goal of improving the quality of sleep, and then you're going to work with the patient to see. And then they may have to go to a counselor. They may, because it may be related to something emotional. They may have to go to a specialist. They may have to go to a sleep center to see if they're having apnea, or where they could put they can watch. People have done that before. Home health nurse. They may have a lot of little different things that they may need to do. So as a result, what you may need to do is implementation, environmental controls, promoting bedtime routines, promoting safety, comfort, activity. You may need to discrete stress reduction, bedtime snacks, pharmacological approaches, and managing sleeping, whatever the specific sleep disturbance. So you got a quiz. A patient suffers from a sleep pattern disturbance. To promote adequate sleep, the most important nursing intervention is what? A, administering a sleep nursing intervention. A, administering a sleep aid. That's not really a nursing intervention. That's more like a medical intervention, really. B, synchronizing the medication treatment and vital signs schedule, encouraging the patient to exercise immediately before sleep, discussing with the patient the benefits of beginning a long-term nighttime medication. So you already know A and D is wrong. It's between B and C. And the correct answer would be synchronizing the medication, treatment, and vital signs schedule. Get them on a schedule where you can promote nursing intervention. Okay, so nursing process implementation, acute care, managing environmental stimuli, safety, comfort measures, maintain activity, reduce sleep disruption. And that's what I was telling you. You got to have realistic goals, you guys, and things that you know that you can do. Okay. Evaluation, patient care. Okay. Compare the patient's progress to expected outcomes. Um, revise the care plan as needed. Um, and determine if patient expectations are met. And so that's where we are with that. Okay, so chapter 44, our final chapter, you guys, is pain management. Along with that pain management, I want you guys to look into um, the I want you guys to look into your analgesics. I'm gonna mention that again. The list that is on the blueprint of the particular medications that's on, make sure that you know them, and make sure that you know the things that I told you for pharmacology. What is some things to look for? how does the medication, first and all, what is an analgesic? What does it do? Okay, then particular medications, how is they working? What's the action? How are they working on the body to take the pain away? Different medications do certain different things. Okay. Some things block receptors. You know what I'm saying? Some things change something in your brain to make you almost like, I don't want to say ignore the pain, but think the pain is not there. So you got to know what those medications are do. And then I want you to know about the doses, appropriate doses. I want you guys to know the appropriate doses. I want you guys to know the side effects and nursing interventions. Nursing interventions. What type of things would you tell the patient? What type of things that you need to do? Do you need to take this or give this on a empty stomach or with some food or, like that type of thing? Because that's important for you to know. That's important. So, so you need to know all of those things. Okay, scientific knowledge base. I want to let you guys know pain is subjective. You have no right to tell nobody what their pain level is. So if you ever hear anybody say anything about pain, I want y'all to know that pain is whatever the experienced person says it is. Pain is whatever the person that's experiencing it says it is. It's not for you to judge. It's not for you. If you want to get a question right, if she pops it on there, you're going to get it right. And you're going to see that somewhere down the line. Pain is what the patient says it is. In other words, you can't, uh, 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 just because like a person has the inability to express their pain level, that doesn't mean that they're not having it. They may not be able to talk. They may have a mental status problem. They may be stoic. It may be cultural. They may. But you got to look and you got to do assessment and you got to look at other things because sometimes some patients will be really afraid of taking pain medicine and that type of thing because they'll feel like, I don't want to get addicted. But it's not even about that. What it's about is that you are basically treating the pain and trying to keep them comfortable. And if you have to let them know this, you're truly having pain, there's no addiction risk, okay? So make sure you tell them that. And make sure you always never withhold a person's pain medicine. That's not your right to do that. Okay? Okay. So physiological pain. Um, I want you guys to know about that. Um, Physiological pain. I want you to know about transduction, converts energy produced by stimuli into electrical energy. Transmission, cellular damage from injury results in the release of excitatory neurotransmission. The difference transmission, the pain stimulants enters the spinal cord, nerve impulse travels along afferent peripheral nerve fibers, and then the A, the fast myelinating delta fibers, and slow unmyelinating fibers is the C. So you probably want to know the difference between the A fiber, which is the result of transmission or first pain, and the C uh, from fiber stimulation or second pain. And I know this is kind of like, but I mean, just if you just know those two things, I don't think a lot of times people get off into a lot of, see, that's what I'm saying right here, where it says physiological pain. I just think y'all should know it. So Perception, central nervous system extracts information from the pain impulse, and the brain interprets information. Okay? And then they have what they call the gate control theory of pain. Pain has emotional and cognitive components in addition to a physical sensation. Gate mechanism in central nervous system regulate or block pain impulse. Pain impulses pass through when a gate is open and are blocked when a gate is closed. Closing the gate is the basis for non-pharmacological pain relief intervention. So that is what the gate is talking about. The gates can be physiological, emotional, or cognitive, you know. So that is the gate control theory of pain, which is probably very, very boring. Uh-huh. Physiological responses, low, moderate intensity pain, superficial pain. I do want y'all to know about the difference between these. Severe or deep pain, which is parasympathetic stimulation, if untreated, can produce progress to chronic pain, and then chronic pain, unrelieved pain that can cause permanent neuroplastic changes. So that's like very, very, and then of course, various people tend to have different, I guess you could say, different responses to it, you know. Okay, acute and chronic pain. I want you to know this chart here, you guys. I want you to know the difference between acute pain, acute, which is transient, chronic. What's the difference with chronic? That means it's persistent, non-cancer, and then chronic episodic occurs sporadically over an extended duration, and then cancer can be acute or chronic, nociceptive or neuropathic. And then you have idiopathic, and that's the pain that nobody knows where it's coming from or where, I do want y'all to know about that. Okay? Know the difference between those five things. I want y'all to know about what referred pain is. That's when a person senses pain in the actual site that's causing them, but the pain will actually occur in a different. That's just like somebody having a heart attack, and then they saying that, oh my God, my left arm is hurting. That's referred pain. Or um my chest is hurting, but my chest is hurting, but I'm experiencing flank. Well, I'm having a heart attack, but I'm experiencing flank pain, or I'm experiencing pain in my lower back. Like it be little stuff. You'd be surprised at the stuff that, like actual individuals what they'll go through. That is, you know, uh, referred pain. Yeah. Okay. Knowledge attitudes, that type of thing. Often they have preconceptions in patients in pain. Some do not believe that their patients are experiencing pain. Okay. Knowledge of nurses and other healthcare providers affects pain management. Too often, nurses allow misconceptions about pain to affect their willingness to provide pain relief, which is really crazy. Remember, I just told you guys, so I don't want to hear um, nothing about, that. So basically, it's a thing where um, y'all need to look at pain as the fifth vital sign. That's what they call it. And you need to assess from 0 to 10. And a lot of times, like with kids and stuff, they have different charts, like this little smiley face. They have little names for the charts. I can't remember them off the top of my head. Um, but you need to know how different things like their cultural background, their spirituality, their, all that type of support systems, all of that affects how a patient uh, has factors. Physiological factors, age, fatigue, neurological, gender. Right. Women, believe it or not, even though they'll say that men may act like that, I have found in my practice that women tend to take pain, more severe pain. Fatigue heightens pain perception if you're tired. Social factors, attention, previous experience. Previous experience. Oh my God, I went to the dentist and I left there. I was jacked up. I was in pain. Da, 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 da. So actually, the next time you go to the dentist, you're going to be expecting something. That can affect your perception. Spiritual factors. They don't want to lose their independence. They don't want to become a burden. Cultural. Uh, they say that certain cultures of people react differently to pain. They say that some cultures are more like um out there with it, scream and holler and cry and don't care. And then there's other cultures that'll be stoic. So you need to know and you need to look, you guys, and you need to look at things like when you're doing your assessment and stuff like that, you need uh you need to look and say to yourself, okay, what type of things can be influencing this pain? So you're gonna look at the nursing process and determine which level of pain will allow your patient to function. When the patient is in acute pain, assess location, severity, and quality. You see, when the patient is more comfortable, collect a more detailed assessment. um, the PQRSTU. Pain is always changing, monitored on a regular basis along with other vital signs. And that's your way of really assessing. Sometimes people tell you they're not in pain and their vital signs be through the roof. Pulse, tachycardic, uh, blood pressure up. They may be diaphoretic and you looking at them like this person is in pain. You know what I'm saying? So sometimes you have to tell a person it's okay for me to give you something for pain. Don't hold on, that's not good. You shouldn't be in pain. So sometimes you have to help a person with that. But keep in mind, it's not your place to judge a person about the pain. Okay. The comprehensive assessment of pain aims to gather information about the cause of a person's pain and determine its effect on his or her ability to function. So you got to do a factual pain assessment, the PQRSTU. Um, let me let y'all see what that is. So patient's expression, I told y'all about that. Patient unable to self-report pain. I do want to tell y'all that um, uh, is infants and children, patients who are critically ill or unconscious, patients with dementia, patients who are mute, patients with an intellectual disability, and patients that are at their end of life. Okay, so remember we was talking about the PQRSTU and stuff. And you got the timing, onset, duration, pattern, precipitating. So the pattern, which is timing, which is, you have to know about those things. So you got the precipitating factors. What leads to the pain? If I sit down, it hurt. If I stand up, it hurt. If I, you know what I'm saying? And it may not be the quality of the pain. Oh, it feels stabbing. It feels this. What do you do to relieve the pain? Well, it hurts when I sit down, but when I stand up, it kind of go away. Where is it located? How severe? It could be on the numerical 1 to 10, 10, and make sure when you say 1 to 10 and you tell them 0 being 0 to 10, 0 being no pain, 10 being the worst unbearable pain, what do you think your level is? And affect the pain on patient. What is it making you do? I can't sleep at night because, oh my gosh, when I eat, it hurts so bad. I done lost 15 pounds, that kind of stuff. Assessing pain on children. Remember, I told you guys it was like the little scale or whatever that they do, and it's called the Wong and Baker. There it was, Wong and Baker, and It was developed in 1988, the year my son was born. Uh, the FACES pain rating scale to assess pain in children. Um, the scale shows 6 cartoon faces ranging from very happy, smiling face for known pain to the worst pain. So y'all might want to know about the 5. And that's easier for a kid. They don't know about that 0 to 10. What are you talking about? The point how you feeling, and they will point. You see what I'm saying? They'll look at the smiley faces, and they tend to understand that better. And they also um then they have like what they call the Oucher pain scale, and the Oucher pain scale shows basic a face of a child and creates levels of discomfort. And so, I mean, people have done like age appropriate type of different things. They even have one kind, and it's like this verbal thing, the verbal descriptive scale, as well as the numerical rating scale. So they got like a lot of little different scales to help the children. So long as you just kind of know or have an idea of what that is, you're good. Okay, let's do a quick quiz. When a smiling and cooperative patient complains of discomfort, nurses caring for this patient often harbor misconceptions about the patient's pain. Which of the following is true? A. Chronic pain is psychological in nature. Patients are the best judges of their pain. And B, which was B, I'm sorry, C. Regular use of narcotic analgesics leads to drug addiction. D. Amount of pain is reflective of actual tissue damage. Which one is following is true? One, B, patients are the best judges of their own pain. Patients are the best judges. Remember, we said that pain is what they say it is. Okay. Nursing process. Well, I always show you guys your nursing diagnosis, risks for caregiver role, strain, ineffective coping, fatigue, impaired physical, acute pain, chronic pain, bathed in self-deficit care, because of the fact that they can't do that. Social isolation. When people in pain, a lot of times they don't want to be around nobody and they don't want to do nothing. I remember I knew when my dad back was hurting because he stopped going fishing. He stopped doing the things that he loved. That's another thing. Sometimes people ask you questions, you guys, about different things like that, and they'll ask you, like, for instance, what if a person's not doing this or this, and he stopped doing it? That's a very good thing to know as far as pain level, or when a person is really not functioning. You might ask them a question like, what do you like to do? And then they'll tell you, I like to garden, but I haven't done it for about a year, you know. Oh, why haven't you done it for a year? Oh, I don't know, my back is hurting. Or they might not even tell you it's because their back is hurting, but you know. Or if somebody, family member say, he used to fish all the time and he just stopped fishing. You be like, So keep that in mind when you're investigating. And then you're going to plan your goals, just like this is the same as with any type of um, thing. A nursing assistant personnel may screen them, but they may not probably do any pain relief therapies unless it's something that's not really invasive, or like as far as giving medicine and that type of thing. Non-pharmacological pain relief measures, reducing pain reception and perception. Um, you can do different things: anticipatory guidance, distraction, cutaneous stimulation, which means that you can like rub them lightly, uh, do some little ice or something on something, briefly, you know what I'm saying? Do little things. Let's take a shower. How would you think that'll feel? You know what I'm saying? That type of thing. Guided imagery and relaxation, decreasing the lights, that type of thing. Those are non-pharmacological things that you can do as a nurse to distract them. As far as that cutane, stimulation to the skin can help a person. You can do a massage, a warm bath, an ice bag. You can do tens. All of these 10 units, those are all simple ways to, because you can buy a tens unit over the counter, you know. So those are like almost like nursing intervention things when we talk about autonomy that you don't really necessarily have to get no order to do. And then acute care pain, and then that's when you go into pharmacological. We talked about the analgesics, you guys. Uh, the most common methods of pain relief is analgesics. There are three types of analgesics: non-opioids, including non-opioids, including acetaminophen, and non-steroidal and anti-inflammatory like NSAIDs. Acetaminophen, that's the same thing as like Tylenol. Non-steroidal and NSAIDs, stuff like Motrin and that kind of stuff. Then you have opioids, which include, narcotics, you guys. And then you have adjuvant or co-analgesics. Those are drugs that they use on top of uh, uh, other drugs that are, um, how can I explain it? Help a person on top of the medicine. You know what I'm saying? So, like for instance, okay, Tylenol is one of the safest analgesics. It has no anti-inflammatory effects and its action is unknown. Non-selective NSAIDs such as aspirin and ibuprofen provide relief for mild to mild acute intermittent pain. One thing about NSAIDs and ibuprofen, they can tear up your stomach. And then you have opioids like analgesics are prescribed for moderate to severe pain. One way to maximize pain relief while potentially decreasing drugs is to administer analgesics on and around the clock. So you're not going to wait until the person just gets a level 10. You know what I'm saying? You gonna give them their pain medicine. Don't be withholding. No, I don't agree with that. Nobody's pain medicine. I do not agree with that. And then the proper use of analgesics require careful assessment, application of pharmacological principles, and common sense. Like, for instance, things like, you guys, this is not your pharmacology class, but I'm just going to throw out some things. Like, for instance, when you give a person morphine, um, morphine can depress the central nervous system. Therefore, they look at how it's, you got to make sure you check their vital signs and you're really checking their breathing, breathing and different things like that. There are things that you can give a person, like you can give them a PCA, which is a patient control analgesic, where it'll administer via their IV, it'll administer a certain amount over a certain time. They push the button, and they have it set where they can't overdose themselves. They can push all day long, but it's only going to administer a certain amount of medicine over a period, a certain amount of hours. Uh, and you just have to teach them. So you will have the infusion pumps, and uh, they got what they call per neural infusion pumps, where there's a catheter that goes right into the surgical wound, and they leave it in place for about 48 hours or so you know. And then you got local anesthetics, like for instance, let's say somebody is getting a skin lesion or a suture in a wound, the drug produces temporary loss of sensation. When you go to the dentist and they get the needle and shoot you in the needle before they work on, that's considered like a local anesthesia. They use stuff like lidocaine and different things like that, temporary numbers, and it's just that potential place. And then they have what they call epidural, which it blocks a group of sensory nerve fibers. A epidural block area, like for instance, they'll give a person like, okay, let's say you got a woman and she's getting ready to get a C-section. They'll give her a epidural, I'm sorry, I'm getting tired, epidural, so that it can block and she won't have no sensation from the chest wall down and could be totally up. You know what I'm saying? She can't move. She don't know what she doing from that. And then they could do a C-section. That's how they did me when I had my son. You know, they have what they call uh, transdermal analgesics and that kind of stuff like that, like patches. Like they used to do I hate to mention fentanyl because, but it's a patch that's placed on the skin. The only thing that I could say about patches is that when you take it off, you got to make sure that you wash really, really good that area, and then you switch up the areas, like that. Don't forget to take off the patch that you got on already, because you'd be surprised how skin is absorption. I do want you guys to know about patients with cancer, and you see the um 1, 2, 3. I want y'all to know what y'all need to do at each level. A non opioid and an adjuvant. So you're not giving a, a, a opioid at this point, to nobody. You're not giving it. Pain percents or increase. So that's like the steps. And so you just need to know that those are the steps. I just told y'all about morphine right here. It says continuous drip of morphine. What did I say the most important thing to assess would be? And I said respiratory rate. A patient has just undergone an appendectomy, When discussing with the patient several pain relief interventions, the most appropriate recommendation would be what? Think about it, you guys. They're coming right out of they're not going to give you a whole lot of information, but it's going to be a PCA, pain management. You don't really know how the person, they're just getting out of, they just did, so they're not going to take no non-opioids or NSAIDs, and you, because they're probably going to be not going to take anything by mouth right now, coming right out of an appendectomy, but PCA, where they can control it. Adjunctive therapy, we don't know if they need adjunctive therapy. That's when you give them medicine on top of some other medicine. A lot of times they give that when people have chronic pain, or when, like right before a surgery, they'll give them something because they know that it's going to be wild. So it's going to be D. Okay, nursing process implementation. Um, you're going to do what you need to do. Restorative and continue opioid failure, pain control medications with chronic pain, and then palliative care in hospice. So palliative care consists of not being in pain. Hospice care consists of end of life therapy. Okay, that's the difference between those. Quick quiz. A post-op for the patient is using PCA. You will evaluate the effectiveness of the medication when. So what they're saying when they say you will evaluate effectiveness, because you'll hear them word things like that, it's basically they're just saying when is it working. Okay? A post-op for the patient is using a PCA. You will evaluate the effectiveness of the medication when you compare assess pain with baseline pain. Body language is incongruent. Anything incongruent, that don't mark that B off. Family members report. Nobody knows better than the patient, so they can't report. B and C is out. And vital signs have returned to baseline. They may, but you want to know the you would definitely go by comparing assessed pain with baseline pain. You know what I'm saying? So you're gonna say they started off because you're trying to see if it's working. They started off with this, and they was a 9 out of 10. They vital signs was all off the pump. You know what I'm saying? You're gonna see everything. So that's more of a full assessment than just D. So you would go with that. So the answer would be A. Evaluation, you're going to make sure that the patient has met their goals. And their goals would be basically that you want them to go from a 9 to a 3 this shift. You want to try to get a person at a level where they are, it's attainable and it's realistic. And then you're going to assess their behaviors, assess the patient if expectations have been met, and use open-ended assessment questions, which means that you don't want to close them off. You're not going to go up to them and say, "Do you hurt?" And they be like, "Yeah." And then that's the end of it. You know, you want more information. Explain to me on what I can do to make this better. Explain to me. That's how you go into all that PQRST. You you know, you want info. Okay? And then safety guidelines, be vigilant during the entire process of medication administration. You're not going to give them medicine and then leave them to walk and ambulate to the bathroom on their own, a post-op. You're going to look at things and you're going to be careful. Okay, set up and prepare medications in distraction-free areas. You want to make sure you're giving them the right thing. And basically, you guys, that is the end my review. I hope I helped some and that you guys were able to I could say pick up some little tips. If not, oh well, you'll have me this time. So don't worry about it. Thanks. And y'all have a nice one. And I hope everything work out for the good. Okay.